Hello, everyone, and welcome to the American Medical Informatics Association's Clinical Informatics Fellows podcast called Go Live. And I'm your interview host, Sana Ali, and I am a primary care physician and clinical informatics fellow in Arizona. And today we have some very special guests from the Arizona Department of Health. And we have Dr. Roberto and Guillermo Adame. And please go ahead and tell us what you do.
Good morning. Hi, Sana. So my name is Irene, and I'm the Vector-Borne and Zoonotic Disease Program Manager at the Arizona Department of Health Services. I also manage the mycotic or mostly valley fever program as well. And I've been here with the agency for more than 9 years. Nice to meet you.
Amazing. Nice to meet you too.
Hey, Sana. Hey, listeners. I'm Guillermo Adame. I'm a vector-borne and zoonotic disease epidemiologist on Irene's team. I was formerly a valley fever epidemiologist for 5 years with Arizona Department of Health Services, but transitioned to the VBZDs, as we call them, or our vector program for shorts, about a year ago. Thank you.
Wonderful. So our topic today is public health informatics, and a little bit about what that is. According to the Center for Disease Control, informaticians translate between different disciplines, such as epidemiologists and IT, and different data languages. And this is to enable communication between people and systems to more effectively protect a population's well-being. And our first question for our guests is, what is public health surveillance?
Hi, Sana. So public health surveillance is the systematic and ongoing collection of data. And through the analysis and interpretation of this data, then we're able to disseminate the findings to, lead a public health action. And, we wanted to talk about public health surveillance because it's really the foundation of many public health activities related to infectious diseases. And so we wanted to give your audience an example of the data that the Office of Infectious Diseases Control at the Arizona Department of Health works with. And just to add a little bit about public health surveillance, so there's different steps. It starts with the infectious disease report, and then through case investigation, more information is added to that initially reported. And then the information is aggregated to look at trends, maybe find, increase of a certain disease, or maybe an outbreak of another disease. And that data, is not just kept in our system, but it's really used to inform the community and healthcare providers that initially reported that information to us. So we really try our best to bring the information back, and make it as useful as possible.
Fabulous. So it's a 4-step process with various professionals at each level.
Exactly.
Where does that surveillance data come from?
So this very first step, so where the reporting information comes from is what we call communicable disease reporting, and it happens with that report that is done. And we'll see in a second who does the reporting, but that report, which then happens ongoing, so that's why it's called surveillance. So, we rely on ongoing reporting of reportable diseases by providers as well as laboratories to start the flow of information and kind of the surveillance cycle that can help us understand what's happening in our communities. And you can find more information on our reporting webpage. This is at www.azhealth.gov/reporting, where we have a lot of details on all the different types of reporting, and we'll cover some examples in the coming slides.
Great. And who should be reporting?
That's a great question. So there's actually quite a bit of important players in the health environment that should report. Healthcare providers, so hospitals, like, for example, infection preventionists within hospitals are usually assigned reporting duties. Healthcare providers in general, so doctors, smaller clinics, and these have their own reporting requirements for hospitals and doctors. And then we have laboratories. All clinical laboratories are mandated to report to the state through the laboratory reporting requirements. And then we have specific lists for schools and shelters and daycare facilities, which also have some limited morbidities that they should be reporting to the local health department. The same is valid for correctional facilities and for veterinarians. Veterinarians, of course, should report diseases that are of concern to human health, in addition to their own reporting of animal diseases to usually the state public health vet. So that's kind of another layer of reporting. So
wow,
all of
so
these,
there's a lot of sources of information to consider.
yes, and that's because we, first of all, we want to be sure that the reporting happens, and so hospitals and laboratory reporting happens in parallel on a certain individual that gets diagnosed and tested. And the other reporting sources are important to understand what's happening in those environments, in daycare facilities and shelters that might not be included in the loop of hospitals or doctors necessarily.
How does this reporting happen? And is it happening as consistently as it should?
So let me give you an example. So in the real world, let's say that one morning you wake up. I'm hopefully not, but I guess one morning it happens that you wake up and you're not feeling great. So you might go to your doctor, and your doctor might diagnose you with, let's say, for example, flu. And then he's quite likely going to order some tests. And so we have two levels of reporting. So once you're diagnosed with the disease, the healthcare provider should report, and those reports in Arizona should go to the local county health departments. And the laboratory that runs the test, once the test comes back positive, if it's included in the reportable diseases, they also have to report, and they report to the state health department. All this reporting comes into one big system. We call it MedSys in Arizona. And so all the information is shared between state and local health departments. And I would say with improvements in electronic reporting, especially for laboratories, I think we have improved timeliness and completeness of reporting overall. But when reporting doesn't happen electronically, sometimes we do still see some incomplete data sometimes.
I see. And MedSys stands for Medical Electronic Disease Surveillance Intelligence System. Is that correct?
Yes. And it's a secure system that enables different users to share information securely. It's web-based, so it's easy to access. Everyone has their own username and password, and it's a great way to share information about an investigation. We have lab reports in the system. We are able to really follow up on all the actions that are taken according to the type of investigation, the type of report that comes in.
Great. Who decides what is reportable?
Good question. So there are two layers of decisions. So one are the recommendations that are made nationally, and these are made by the Council of State and Territorial Epidemiologists, or CSE, which is our big professional organizations for epidemiologists, which also works closely with the Center of Disease Control and Prevention, or CDC. So they came up with a list of notifiable conditions that they like, all states to basically report to them. However, the specific legal requirements are delineated at state level. Every state might have slightly different priorities based on the epidemiology and the disease, and the environment. So not all states might decide that all the notifiable diseases should be reportable. And so in Arizona, ultimately, it's our statutes that delineates what is reportable. But very often, notifiable conditions and reportable by state align pretty closely.
Oh, that makes sense. So like Lyme disease is mostly prevalent in the Northeast, so Arizona might not have a requirement for that.
Yeah. Lyme is still reportable in Arizona because we want to, keep track also of cases, even if they're infected elsewhere. But yeah, there can be some local differences due to different epidemiology of a certain disease. Yeah.
Okay, great. Is there somewhere that I can find the list of reportable diseases in Arizona?
Yes, you can find everything on our website. The specific page for provider, you can find it at the azdhs.gov/provider reporting. And in that, you can find a table that lists about 90 reportable morbidities. These should be reported to the local health department. And on that page, you see also options of how to report those. We have a report form. You have the fax information for the local health department, or other ways in which you can report, including, if you like, you can be added as a MedSys user and report directly into MedSys. So the list of the 90 morbidities comes from the rules, and they're listed in alphabetical orders. We also try to prioritize them depending on the severity of the disease and the type of public health actions that can happen. And so we have some timeliness of reporting attached to each morbidity, just to give a general awareness to providers on how urgent some reporting needs to be. For example, something like anthrax or botulism that needs immediate attention should be reported within 24 hours of even suspecting it. So we would want a phone call even during weekends, and we have after-hour numbers for us or county health departments listed on our website. Other conditions such as maybe flu that are less, urgent, we want a report within 5 working days. So these are some kind of guidelines that we have included in our rules for reporting.
That's really good to know that doctors are not the only ones that are on call like that.
Yes.
And what sort of information is required in that report?
So we understand that reporting can be burdensome, so we really have been trying to highlight the essential information. We then, during case investigation, add more through other ways. But initially, we really want at least, the patient name and date of birth. If possible, having gender, race, ethnicity would be also important. Address is essential also for us because it's important to understand the county of residence, since many actions are based on the county. The disease that is suspected or has been diagnosed. If possible, having a diagnosis or onset date, and some information on test results. And then the provider reporting, making the report. So at least the contact information for them, that's essential, because then the county health department would follow up according to the morbidity.
Makes sense.
And on our website, you can find an example and actually the PDF of a reporting form. If you prefer to report by fax, we have a form with fields that you can fill so that you are sure you report all the required information to us.
Great. And from what I understand, since since the onset of the electronic medical record, there are ways to electronically report, and there are efforts to promote interoperability between systems and databases. And I read on the website that there's an Arizona State Immunization Information System and database. There's electronic lab reporting that hospitals and large clinics who have it set up can go ahead and do that, or anyone who wants to set it up. Syndromic surveillance, a cancer registry, and electronic case reporting. So it looks like there's a lot that's going on digitally.
Yeah, that's right. That's right. ELR specifically, so electronic laboratory reporting, does feed into our MedSys system. And so, like I mentioned earlier, a lot of the reporting has increased exponentially in terms of completeness and timeliness in the last 5 to 10 years due to the increase in ELR. But in addition to our MedSys system, we have these other systems like the immunization or syndromic surveillance or cancer registry that exist in Arizona. And there is a lot of health data that is collected. And I think in the future, we're trying to move to a more interoperable system where you can more easily link all these databases together and more efficiently share information in and kind of out through electronic, also case reporting in addition to lab reporting. So there's a lot, I think, of hopes for the future to better integrate the data and make it even more efficient.
That's great to hear about the data sharing. And what are the legal requirements for reporting?
So I have mentioned the table and the list of reportable morbidities. So all these details on reporting are really part of the our rules in Arizona. They're part of the Arizona Revised Statute, and you can find a specific link to our website if you want to read more. So they're really rules. We don't we don't enforce it too strictly. But I think it's important for providers and lab to know that this is the rule, and we do it really to learn more about what's happening in our community and ultimately to keep ourselves and people around us safe. So there is a reason to do it. Yeah.
Absolutely. The laws are there for a reason. And what happens after you receive a report?
So we have looked at the first step of reporting and what should be reported. And like I said, we would love to have a lot of information reported initially, but quite often we only get minimal information. And so it's during case investigation that we collect additional information that are really necessary for follow-up. During case investigation, usually the county health department takes that initial report, and according to the morbidity, basically collects more information. And this is usually done by ordering, requesting medical records. So really looking into the report and the individual much more. We look at other tests that might have been ordered. We look at the clinical information, the onset. We try to really narrow down if that's the specific morbidity, and based on the test results, we then classify the case. We also interview the patient. So the local investigator interviews the patient to confirm the clinical symptoms and the dates found in the medical records, to get any additional information not in the records. For example, sometimes travel history is not always included in the medical records. I think sometimes providers don't think a whole lot about asking travel history when they maybe should. And so we sometimes have to ask some of that type of information directly to the patient. At that point, also education is provided. So according to the morbidity of interest, the patient is informed about, how do you get a certain morbidity, how can you prevent it in the future. We might also ask if other people in the household are unwell, if they've been seen. Again, this really depends on the morbidity of interest. For hospital reporting, sometimes we're also able to connect with infection preventionists who might already have some of the medical records and information. And sometimes we might also need to go back to the healthcare provider, again, if we don't find all the needed information in the other sources. We know that providers are very busy, so we try not to bother them too much, but sometimes we do need to reach out to them as well.
Yeah, and clinical administrators can help to send that information, and sounds like that medical history is really important to determine risk factors for disease if it's not known, or even establish patterns. And
yeah,
that
so
leads us
we
into
look
your
at
next
that,
topic.
especially for we narrow really down a few key information of interest based on disease. It's usually mostly to confirm the clinical symptoms and ensure that they're compatible with the lab report. And we'll see in a bit how we use that in classifying a case. We might also look at potentially history of vaccinations, if that helps explains or rule out other diseases, or it might help interpret lab results. It really depends on the disease. And part of the case investigation is also to look at the potential exposure. Let's say that we're talking about vector diseases, if there is concern for mosquitoes around the home, and this is maybe a report for West Nile, then we connect to local environmental health, and they take actions based on what they the information available, and then according to the disease, we might identify other exposures, such for enteric diseases. They might be able to pinpoint a specific food item that maybe needs to be recalled. This is usually after not just a case, but a cluster investigation, an outbreak, and so on.
And cluster,
yeah,
sounds like the cluster investigations are definitely important for things like norovirus. Typically, you hear about that on cruise ships or daycares, and so
yes.
that's definitely important information.
Yes. And so for diseases such as norovirus or other enteric diseases, there is a lot of really thorough case investigation that is done. And quite often, we have a team actually of disease investigators, because a lot of work goes into interviewing cases, and often they need to interview them several times using really extensive questionnaires, because as they learn more about possible food exposures, they're going to add those questions. And so they kind of refine the questionnaire as they go, with the hope of finding, the source. So there's a lot of effort that goes into case investigation, especially for some diseases. Yes.
Yeah, and this is so important for us to have the resources for this, because it affects all of us. And in the news, I recently heard about hepatitis A and frozen fruit, and I heard about bacterial infection from over-the-counter eye drops, and it took a long time for the source of the infection to be investigated. So it's so important, the work that you're doing. And so how are these cases counted?
So with all this information that we collect through the case report, provider report, medical records, interview, and so on, we then put all of that together. And CDC and CST, the same group that makes a notifiable list of conditions, they also create definitions for each disease that can be used to classify the disease. And that helps us to count cases of disease, and to count them in the same way, no matter if you get it in Arizona or if you are, public health in another state, so that then nationally we count the same thing. And so CDC can have good data across the United States on like cases of Salmonella or transient West Nile virus. So these case definitions are made really to count consistently across states, and each state still has the power to a little bit, change as they see fit some of the definitions, but mostly they kind of take the main guidelines and apply them in their state. And this is also how we do it. And you can find, the case definition manual on our website. This is really meant to be used by public health. So, cases that we defined as confirmed and probable are not necessarily in alignment with what healthcare providers might define as a diagnosis of a certain disease. There are some differences there because these definitions are used for different purposes. But these are used within public health to really count, being able to aggregate and then look at trends. And just to say a couple of more things about the case definition. So I mentioned the importance of looking at the clinical information in the medical record. So that allows us to find out if the patient had clinically compatible symptoms. And so we take that piece of information and then we look at what lab results have been reported. Are those compatible with an acute infection of that disease? Because sometimes you might have a positive lab result that though might be indicative of a vaccination, for example, or a past infection. And surveillance really wants to focus on ongoing disease incidents. And then sometimes we also have additional criteria. But putting all of those together, you basically then have definitions that help you classify the case as you might have a confirmed case, a probable case, or sometimes we also have suspect cases that are not really counted at the end, but they kind of could have been if we had more information or maybe additional testing. And sometimes we cannot always test for, run all the possible tests to confirm. So sometimes part of it is also depending on what tests have been run. And then confirmed and probable cases are aggregated, and that is what makes up our case count for a certain disease. And those are also the cases that are reported to CDC, and then are included in the national stats. So that's how it works.
That's really important to know that it's not black and white, and that there's varying levels of certainty. And so it sounds like it's not easy to classify these diseases. And when I was looking at the West Nile and St. Louis encephalitis virus case classification, it was a long 6-page document with multiple steps. And as you mentioned, that also varies by disease, that some diseases are more complex to classify and others are easier. Is that
exactly
correct?
Yeah, so frankly, it really depends on the disease and on the commercial testing available and how good that commercial testing is. So some diseases are straightforward, and if you have good commercial testing and a pretty clear clinical picture, as long as we can confirm we have those test results clinically compatible, that might make it confirmed. For some diseases where you have commercial labs that might, potentially cross-react with other diseases, and this is quite common for some of the mosquito-borne diseases like arboviral diseases. Some of the commercially available IgM tests are not very specific for one virus, but may cross-react with similar viruses, and so that complicates the whole picture. And then to confirm a case, we need to basically rule out some of the other viruses. And so that makes it a bit complicated. We might also need to do confirmatory testing according to the disease. And that adds another layer, of complexity. That really depends on the disease.
Yeah, very interesting. You really have to take into account the sensitivity and specificity of the test when you're classifying the disease. Well, and then where does Arizona store their surveillance data? I think we already touched on this a bit.
Yeah, we did. So MATSIS, it's our medical electronic disease surveillance intelligence system. I wanted to emphasize how important and useful it is to have a good centralized system where you have all the information. Like I said, it's secure because it does include health personal identifier information and reports, so it has to be secure. It's person-based, so we have like a record for each person, and then each person can have multiple morbidities. It's centralized, so we have all the counties and tribes that are in MATSIS. We even actually also have some of our partners in Sonora. They have their own MATSIS section, and so these different jurisdictions can work together. Each jurisdiction can only see their own cases, of course, for confidentiality. But if the investigation requires, cases can be shared across jurisdictions, and that helps, very much the investigation, because it's a really quick way to share information instead of sending numerous emails. It's really secure, and you can add a lot of information and notes, and everything is in one place.
Fantastic. How is the surveillance data analyzed?
So after all the data is collected and put in MATSIS, and we have classified the cases, and so we finally have numbers, we can take that out from MATSIS and look at the numbers, right? Epidemiologists are really supposed to look at the numbers at population level to look and create the picture and understand how the disease affects the population. So a lot of our job is around looking at trends, but it's also about sharing, that information. We create and update dashboards that are also posted on our website. You can look at, year to date. So what's happening in the current year by category or by specific disease. You can also look at it by county. So, you can get a snapshot of, what are the most common infectious diseases in your county this year. We also have a lot of, more detailed dashboards that look at seasonal trends and compare current data with past data. We have a really comprehensive influenza dashboard where you can look at seasons through the years. You can look at, population affected, different influenza type. We can usually look at the population affected based on the information collected. That's why reporting, collecting information is key, because by collecting, the sex and gender, race, ethnicity of the cases, then we can get an idea of what is the population most affected. If we didn't have that information, we wouldn't be able to look at that detail, right? We would only look at trends in general. We also look at cases in a temporal way. So when are the cases increasing? What is the seasonality of a certain disease? And that can inform us on when we would expect a peak maybe next season, and that can be useful for messaging, and so on. So there's plenty of different ways that we can look at the data.
Awesome. How is the surveillance data disseminated?
So I mentioned that for us, it's very important to not just look at the data and keep it in our system, or maybe making really nice graphs that we are the only one to use. But we really want to bring this awareness out to the community and to the healthcare community. And we try our best to do that. We do that by posting graphs and updating dashboards on our website. We also have other ways for urgent communication. We have the Health Alert Network, which is a network of providers. It's basically a listserv that you sign up for, and then we use it to disseminate important information, such as an outbreak, maybe a recall, or some type of a emergent situation that needs pretty urgent attention. We also have a phone app that was developed some years back for healthcare providers in Arizona that lists diseases in Arizona, talks about reportable diseases, and prevention action and some numbers for each disease. And through that app, we can also push out notifications for, again, outbreaks and situations that are of interest. Then we use other ways like blog posts on our website, or if the situation is really important and we need communication to the general public, we may also decide to do like a press release.
Very cool. I just downloaded it.
Yeah, so if you go to www.azhealth.gov/IDAZ, you can download for free our ADAZ app, and it's mostly for healthcare providers, but most of the epidemiologists also have it. It has a good list of infectious diseases reportable in Arizona. You can learn more about them. You can look at some of the trends, and you can keep informed with alerts if anything comes up, outbreaks and such.
Great. And now a couple diseases that are more common in Arizona than other states are coccidiomycosis and West Nile virus. So thank you for going into detail about West Nile virus surveillance. It'll be interesting to hear what are the efforts to measure and treat this disease.
Yeah, we wanted to provide an example of the data and the steps and the actions that we take, and we thought that West Nile virus was a good example, and Guillermo will be talking to you about some of this.
Awesome. So how does surveillance work for West Nile virus specifically?
Yeah, I'll tag in for a bit here, and I'm sure we didn't already mention it, and most of your listeners know already, but West Nile virus is a mosquito-borne virus and our most common vector-borne disease in Arizona. But a little bit of history about West Nile. It was first isolated in a patient in 1937 in the West Nile district of Uganda. So it's been around for a while, but didn't make its way to the U.S. until 1999. It was first detected in New York City that summer, then made its way across the country to Arizona. We saw our first locally acquired cases in 2003. And then, as we talked about, made it a reportable disease for Arizona to public health in 2004. And so we've, for human surveillance, and we've also done surveillance on select chicken flocks as well as horses and birds, especially in the past, but current surveillance is primarily focused on human cases as well as positive mosquitoes.
Sounds like a lot of work. Mosquitoes are not easy to track down.
Well, we definitely have quite a few of them in Arizona. I think some people are surprised, at least people who don't live in Arizona are surprised that mosquitoes can survive in the desert environments. But they do. They find their niches,
and all they need is a little puddle of water to reproduce.
Just a little bit of standing water. Yes, exactly. And the two species in Arizona, mosquito species that transmit West Nile virus are Culex tarsalis and Culex quincefasciatus, or called quink for short. And West Nile virus in nature, it has a transmission cycle with birds. Birds are what's called an amplifying host. And so if a mosquito is infected with West Nile virus, and they can infect birds when they take a blood meal, and then the birds can develop a high enough level of virus or viremia in their blood that a subsequent mosquito will get infected with West Nile virus when they when they feed off of birds. Humans and other mammals like horses are called dead end hosts. And so we actually, when we get infected with West Nile virus, we don't develop a high enough viremia. So if a non-infected mosquito feeds off of an infected human, that virus will not be transmitted back to mosquitoes. And so birds are of particular interest, and there have been some studies, and the predominant amplifying birds for West Nile virus in Arizona are for those watching online and not listening. We do have slides of these bird pictures there of mourning doves on the top left, and then house sparrows, house finches, and then grackles on the bottom right there.
Mm-hmm. What's special about West Nile virus case investigation and data?
Yeah, we so as I mentioned, we don't just look at human data. We have there's a One Health component with the environment and with animals, with birds and with mosquitoes, of course, as well. And so it's a little bit special that public health and vector control agencies work together during this investigation. We talked about the surveillance process coming in from, we get an infectious disease report, and that triggers a case investigation, which the local health departments will attempt case interviews and potentially a medical record review as well. If the case is at least maybe not answering, maybe lost the follow-up, then requesting medical record reviews to see if they're, what their symptoms are, if they're clinically compatible, potentially if they have mosquito exposure, where that was. And then we mentioned that West Nile virus and St. Louis encephalitis virus are relatively closely related flaviviruses, and there can be cross-reactivity with those tests. And so we'll try to get that positive sample sent to the state public health laboratory for more specific testing to try to differentiate if it was, the person was infected truly with West Nile virus, or maybe it was actually an SLE virus causing their infection. And then, we'll communicate our findings to local vector control agencies for potential vector control interventions, such as fogging, for example.
Which West Nile virus tests are commonly reported?
Yeah, so West Nile virus tests are commercially available, and those are usually the first test that we receive for West Nile virus patients. First test that providers order will be from a commercial lab, and in 2021, the commercial labs that sent most of the West Nile virus positives to us, the public health, were Sonora Test, ARUP, LabCorp, Mayo Clinic, and Quest Diagnostics. And we have a process in place where LabCorp, ARUP, and Quest, they automatically send any positive West Nile virus sample. They'll forward that on to our state lab for that kind of more specific testing I mentioned. The rest do not have this automatic process in place and do require a specimen sample request. And so getting to our state lab, they perform an IgM MAC ELISA test for both West Nile virus and St. Louis encephalitis virus on the same specimens, on either serum or CSF specimens. And sometimes that can't quite differentiate if it's truly a West Nile or an SLE infection. And so if needed, the state lab or potentially CDC can perform a PRNP, which is a plaque reduction neutralization test when needed. And that's a very, very specific test.
Which trends in West Nile virus have we seen in Arizona?
Yeah, so as I mentioned, we saw our first locally acquired cases back in 2003, and then made West Nile virus reportable to public health for the next year in 2004. And for those who are only listening and not watching, I've got a bar charts of our human cases over time from 2003 to 2021, and we have a historical median of 108 human cases, with generally alternating cycles of low years followed by high years and then low years, etc. Hasn't always held true, but it mostly has. And so so yeah, the median is at 108, and for those watching, you can see that there's a major anomaly here in 2021. Again, the median was 108, but historically, but we had about 1,700 cases reported in 2021, which is about 16 times higher than the median.
Wow,
which was certainly unexpected.
Yeah, and partially attributed to the snowfall the winter prior and the level of the Colorado River, from what I understand.
There may have been a few different reasons, and but yeah, this was certainly. I mean, as always, when we see an increase, we have to wonder: is this a real increase, or is there some other artifact that's driving the increase in case counts? And I think it clearly, you know, was such a large increase. There was some sort of real increase, but we always wonder how much of that is real, how much of that is a potential artifact, such as, you know, increased testing, potentially increased healthcare seeking behavior from the public, things like that. And so certainly worth investigating, right?
True. So most of the time, more tests means more positive tests. Makes sense.
Yeah, right. Yeah, the more you look, the more you find, and vice versa as well. So yeah, but just a little more on kind of how crazy that 2021 year was. We had 49 cases alone on September 20th, and remember the median is 108, so it's almost half of the median for a whole year in one day. And for that week of September 19th, we had 269 cases, and so that was 2.5 times more than really just about in any entire full year season since 2005. And for that whole month of September, 2021, we had 883 cases. So pretty extraordinary month and year there.
And the majority of cases were being reported from hospitals, is that correct?
I believe so. Irene can correct me if I'm wrong, but yeah, most of our cases we get from people who are more severe, have a more severe disease. You know, most people who get infected with West Nile virus are asymptomatic, actually, and so they usually, you know, they won't seek healthcare. Sometimes they're caught incidentally,
right,
going in for different, you know, another reason or potential blood transfusion screening. But most of our cases have neuroinvasive disease and are usually hospitalized for that. Anything to add, Irene?
Yes, no, I agree. We see the preponderance of the cases being neuroinvasive. So I don't have quite the number in front of me, but I think the majority would be hospitalized. Sometimes we also see just you know, fever, and so those are not hospitalized, but they would still be counted if they have a positive results. But the vast majority, 80% of our cases tends to be neuroinvasive, and so they're quite likely hospitalized. Yes.
Gotcha. And are these trends predictable? You kind of pointed out that from year to year, you know, that may not be the case.
Right. Yeah. Yes and no. So general rule of thumb is that alternating cycle of high and low years, and so usually we can expect, you know, I guess a certain range of cases, or whether it's going to be higher or a lower year. But as I mentioned, that hasn't always held true. And the another, I guess, bit more difficult thing to predict is when in the year, we're going to see the seasonality essentially. When in the year are we going to have an early season, a later season? When are we going to see the majority of our cases? And for those listening, I have a line graph of our cases by week, our human case counts. And so you can see some years we have a bit earlier in the season, such as 2019 and 2004. 2004 was early. 50% of our cases were reported in July. And 2010 was average, generally what we usually see. 25, a quarter of our cases reported in July, a quarter of them in August. And then 2021, you can see, was quite a late year. Most of our cases reported in September, and then about half in October. And so but there has been a bit of a trend, you could say, with early seasons, such as 2004. And this is hard to see from the line graph, so you have to trust me. But with 2004 and 2015 and 2019, they appear to be followed. Those low seasons appear to be followed, or I'm sorry, not low seasons, the early seasons, followed by a cycle of 3 to 5 progressively later seasons. And we kind of did see that with 2019. That early season I mentioned was our earliest we've ever seen, and then 2 years later was our latest season, 2021, that we've ever had in that crazy outbreak year. So potential correlation there with how early the 2019 season was, potential driver for that significant outbreak year in 2021. And then here is just, for those watching, just another way to visualize the data from the previous graph. And it's just a stacked bar charts of our yearly and monthly trends. And so you can kind of a nice way to see when the majority of cases were reported by month. And so I mentioned that 2004 early season, you can see most cases reported in July. Same thing for 2019, mostly in July. And then those 2 years later in 2021, about half of our cases were reported pretty late in October. And most of West Nile virus cases are reported May through November. So getting so many cases in October was quite late.
Yeah. Did all of the counties see an increase in West Nile virus cases? And keeping in mind there are also tribal counties in Arizona, and various municipalities and environments as well. Right.
Yeah, it's a great question. It was this outbreak. How localized was this? Was this localized to one county? Was it localized to one tribe? One zip code even? Was there just a major flooding in a certain area that was driving all of this? And so we wanted to look, at kind of the incidence rates just across the counties, and the tribal communities, their potential cases do fit, within the different county that they're located in, that the residents located in. And so just looking at the incidence rates, we saw significantly higher incidence rates across more than just one county. We saw about 10 times higher rates than average across 4 different counties: Gila, Maricopa, Pima, and Pinal. And Maricopa and Pinal in particular had roughly 30 times higher rates than we usually see. And so essentially this wasn't localized to one county, and not even just mostly South Central Arizona. 99% of our cases did come from 3 counties, and Maricopa, Pima, and Pinal.
Of course, there's more people that live in those counties, and more testing resources as well, right?
Yep, absolutely. So yeah, Maricopa, which is where Phoenix is located, had the vast majority of the cases at over 1,450 out of that 1,700 that I mentioned on the year. And the Phoenix metro area has, I want to say, like 4 million people. Someone can fact check me. I think like 4 million, which is about half the state's population. alone. And so yeah, the testing resources, and so that's why it's important to look at rates and not just strictly case counts.
Yeah. Phoenix
Mhm.
Phoenix has 1.6 million and Arizona has over 7 million.
Yeah, I think that's Phoenix proper has 1.6. I think the metro region has even
More.
than
Gotcha.
that. So yeah, looking even at northern Arizona, we had 13 at the whole state. We had 13 out of our 15 counties reported at least one case this year, and usually we see around seven counties report one case, and 8 counties don't report any cases on average. And of course, northern Arizona, that range from one to 5 cases. So it's not many, but nevertheless, it's the largest amount of counties that that have ever reported at least one case of West Nile virus in Arizona in a year.
Well, did the outbreak affect specific people within the population who were more vulnerable?
Yeah, another great question. Yeah, what's going on? Is it more younger people getting tested for some reason, or even older, more males than females? What's going on here? And in short, so the answer was no. We really saw the same kind of demographics. The median age for 2021 was 66, versus the 5-year median of 64 years old. 58% males reported in 2021 compared to 57, the historical average. And then
It sounds like the older patients who might be immunocompromised or have severe diabetes are more likely to get that neuroinvasive disease as well.
Yeah, older patients are definitely at higher risk for severe disease. Definitely, which is common with with infectious diseases. But like you mentioned, it was important to look at the severe disease as well. I kind of alluded to earlier. We usually see 63% of our reported cases have neuroinvasive disease, and so what if that number was lower in 2021? What if we saw only 40% of our cases were neuroinvasive, and 60% were less severe, non-neuroinvasive? That might indicate, like we mentioned, some sort of increase in testing around the states, maybe some increased healthcare seeking behavior, potential provider and or public education campaigns. But we did not see that. We saw actually a slightly higher proportion of neuroinvasive disease at 66% compared to 63, the historical median. So really not much of a change there. And then case fatality rates were also roughly equal to average, 7% overall and 10% for neuroinvasive disease.
And what about the surveillance of mosquitoes? You mentioned people. What can you tell me about the mosquito surveillance in Arizona?
Yeah, I'm gonna pass it back off to Irene to cover these.
Yeah, thanks so much, Guillermo, for covering West Nile virus surveillance. And as Guillermo was saying, that West Nile virus is special because not only it's a big health concern in Arizona, but also makes use of not just human surveillance data, but also vectors, so mosquito surveillance. So mosquito surveillance relies on local vector control agencies for collection and some of the testing. And so, as you can imagine, that really, the resources for that vary really by county and jurisdiction. We do have in Arizona mosquito surveillance that is conducted at different level in about 9 out of the 15 counties. But overall, counties that have the most resources are the ones with the most populated centers, especially Maricopa County. We just mentioned how populated and big Phoenix metropolitan area is, and Maricopa County has a great vector control division. They have a lot of resources, and so they work very well and very closely with their public health counterpart, and they're able to really track very well, and they have great vector surveillance data. So what they have is, trapping data. They look at the number of mosquitoes trapped and the species of mosquitoes. And they also are able to test mosquitoes for viruses of concern such as West Nile virus. In addition to surveilling mosquitoes, some jurisdictions are also able to do control. That also really varies by jurisdiction and resources. For Maricopa County, they are able to do different activities, including larviciding, so that it kills, the larvae before the mosquitoes becomes adult. In some areas, they might have standing water. And then they also can do fogging, so that's against the adult mosquito. And that is done according to certain, protocols and thresholds, and they do it mostly at night. But a lot of this information, if you are interested, is available on their website and is, publicly available. So testing also happens at the local vector control agency if they have the resources to do so, or our state lab can also test mosquitoes for viruses of interest, and that's how we, learn more about what's happening in the mosquitoes.
Yeah, and it sounds like another reason, other than resources, that counties have differing vector control strategies is because there is no 100% effective strategy for killing mosquitoes or preventing their reproduction, and there's kind of inconclusive evidence for effectiveness. And I know that the fogging of the ponds, sometimes the chemical called pyrethrin is used, which is derived from a chrysanthemum flower. Sometimes gambusia fish are used to eat the larvae. In Florida, there was even a genetically modified mosquito being used to see if that could limit reproduction. But it sounds like nothing has been 100% effective. And I know that because of that, there's innovation happening in industry. Microsoft and Gates Foundation are looking into ways to control this better, because vector-borne diseases are a major cause of morbidity and mortality around the world.
Mm-hmm.
And
there's definitely different options, for controlling mosquitoes. Like I said, even you can focus on the larvae, and really the best management should really focus on a few different options, right? You want to kill the mosquitoes before they become adults, but there's also limitations in how much you can do that, and then once you have the adults, you also have to do something with the adults. I would say there certainly are a lot of different options, but I think that there is pretty good protocols in place for some of the local vector control agencies. So I would say we do have some standard tools that we can use, but for sure it's a challenge. You can imagine controlling and trapping in such a vast area. It's not so easy, but I think there is a lot of work it's happening, and a lot of residents don't know how much is happening. And I have to say something else that I always like to add when talking about mosquitoes is that many people think that it's the responsibility of the city or the county to take care of breeding sites. That's partly true. So they surely work on parks and areas that are public, but we are all responsible of taking care of possible breeding sites in our own backyard. If there's issues, like if you have a green pool, you can contact them and they can help you with that. So you can work definitely with your local vector control to help you. But the responsibility also lies with each one of us as well.
That's great to know that it's a shared responsibility, and we should all be on the lookout for dangerous situations.
Yeah.
And where is the mosquito surveillance data stored?
So in Arizona, mosquito surveillance data is not included in our big, METSIS database because it's a different type of data that really needs different type of requirements and entry. And so we have actually been using a platform that was created in California, and many vector control agencies in California have been using for many years. And this has been expanded to other states. And we adopted this recently, relatively recently in 2020. And it's an online secure platform where different vector control agencies can enter their data. So the platform is called VectorServe, and the Arizona is the Arizona Serve, but it's the same platform. And it has really helped us to put all the local vector control data together. And it has also provided some tools to the local vector control agencies that they can use if they want, as well as a map that is actually publicly available where people can have a look at what's happening in Arizona.
Great. What trends did we see in positive mosquitoes in 2021?
So mostly due to the fact that Maricopa County and Central Arizona, where many of our West Nile virus cases happen, have a good vector control surveillance. We really have seen in the past that positive mosquitoes, and mosquitoes are actually counted in what are called pools of group of mosquitoes of the same species that are tested together. So we have seen in the past that the number of those positive pools align really well with the number of cases. They're not a one-to-one relationship, but we often see that an increase in the number of positive pools over how many pools are tested is an indication of an increase in cases coming maybe a few weeks later. And so in 2021, we had, in the same way that we had an exceptional amount of cases, we also had a record positive number of mosquito pools. And they picked, so we had a total of more than 900, and previous record, I think, was about 500, about half of that, I believe. And they picked in September, so kind of closely preceding a couple of weeks to pick a number of cases. The majority were from the central counties. We did have also some positive pools in some of the western counties, Mojave, La Paz, and then Yuma County as well.
So it sounds like the mosquitoes did not take a break during the COVID pandemic, and they did not stay home. Did the trends? Yeah.
Yeah, and especially in 2021, there is a lot of factors that go into trends in positive mosquito pools and in humans. But generally, we have seen that trends in positive pools, like I said, align well with number of cases. There is a specific indicator that Maricopa Vector Control uses, and it's called the vector index, which basically looks at the number of positive pools over how many pools were trapped. So it's a bit of a rate of disease almost. And they look at it for the two different Culex species. And we've seen historically that precedes the peak of cases for about a couple of weeks. Also, something useful if you live in Maricopa County is the fact that, throughout the summer, studies looking at mosquito surveillance data have shown that we see a peak of, abundance of mosquitoes at the beginning of the summer. So as the weather warms up, there is a increase in mosquito abundance. But then as the really peak heat of the summer, so July mostly really warms up a lot, there is also a downtrend in abundance of mosquitoes. So when it's too hot for mosquitoes too, which is, I guess, good for us. But then as later in the summer, we get rains and the humidity increases and the temperature decreases a little bit, then that's when we usually see an increase also in the positive pools. So that vector index tends to increase at that point, and that's what we saw in 2021. But every season is a little different, but these are usually kind of the trends in mosquito surveillance and
wow, that's really interesting to see the trend between the human cases and the mosquito cases. Yeah. And do we know why the 2021 West Nile virus outbreak happened? It sounds like there's multiple factors.
Yeah, so, Guillermo, I think, mentioned some of this. Really, there is no single answer. Definitely, I think climate and the rainy season played a role. So we had I believe the fall and the winter before summer 2021 were exceptionally wet, especially for Phoenix. We also had rains during the season, so some monsoon activity that summer. And we believe that, the climate influences both the bird population, which Guillermo mentioned is the reservoir of the virus. So usually the more lush the environment before the summer, the more generally the bird population might be. And so they might, then have a more exposure to, if there's more birds, potentially amplify the virus more and have more exposure to mosquitoes. And then if we have that monsoon season and the right conditions, the mosquitoes then amplify the virus at that point even more, and they can transmit it more. But it's not a one-to-one. When we look at historical data, we've seen other years that were really wet, and we have not seen this type of outbreak in other years, luckily. So there is a lot more, and we are trying to understand this better. We're also trying to think about other, factors such as maybe human activity, maybe more people moving to Arizona, being immune potentially to, being not immune to West Nile. That it's kind of a little difficult to study. But the other thing that we were able to do was to look also at the viral strain through collaborators. We also looked at whether this virus that we had in 2021 was maybe different from different previous years. And we did not find any evidence that was the case. So we've been able to look at a few of these different aspects, but we're hoping in the future to use all the data that we've been collecting, human and mosquito, and also have our academic collaborators add climate data and some bird population modeling to try and really help us better understand what has happened and how can we best prevent future outbreaks and have a better prediction of some of the seasons in the future.
Very interesting. So more collaboration is needed between fields. Wow.
Yes, and we are very lucky that we've been working with both Northern Arizona University, TGen, as well as ASU and University of Arizona. We have a lot of really good collaborators that are helping us answer some of these questions.
Fabulous. So I wanted to thank you so much for your time, Irene and Guillermo, and thank you so much for sharing your data analysis techniques, your surveillance techniques. And it's so important that we have an interface between medicine and public health. And I really appreciate all this information. Thank you so much. And here's some other resources from the CDC's Public Health Informatics Fellowship Program. They have a program for that. And also Public Health Informatics Institute has some self-assessment toolkits for health departments and public health agencies. And of course, your website, the Arizona Department of Health .gov, azhealth.gov. Thank you so much for your time.
It was our pleasure. Thank you.
Thank you for having us.
Absolutely.